Group 1 pulmonary arterial hypertension includes pulmonary hypertension in association with connective tissue disease, and all of the medications that have been approved for Group 1 PAH can be used for patients with collagen vascular disease, whether it be scleroderma or rheumatoid arthritis or systemic lupus. So there really isn't any limitations to use of the FDA-approved Group 1 PAH medications in that subpopulation. In liver disease, it's a bit more challenging because some of the medications have had a history of potentially affecting the liver in an adverse way. And it's a rarer diagnosis. So not all of the studies of medications for pulmonary arterial hypertension have included portal pulmonary hypertension in the efficacy studies to show benefit. So our information is a bit more limited. We do, however, know, based on some fairly recent studies, that macitentan, which is an endothelin receptor antagonist, has shown benefit in a study called Portico. There are some open label studies with the other medications that have showed benefit. So we have experience in pulmonary hypertension centers with all of these medications, generally with one or two exceptions, for portal pulmonary hypertension. But it does require some additional judgment and individualization to the patient. For chronic thromboembolic disease, pulmonary hypertension, Group 4 PH, the only medication that has FDA approval is Sigwet. And it's very important to understand that a significant number of those patients can be cured with surgery. So the initial part of the evaluation for Group 4 is to see whether or not a patient might be eligible for surgery, which has an 85% plus chance of curing the pulmonary hypertension. If they're not eligible for surgery, or they may have had surgery and they're one of the 15% who had some persistence of the pulmonary hypertension, then they would be eligible for consideration for treatment with Sigwet as the only FDA-approved medication. There are some other medications that have shown benefit in trials. Macitentan was shown to have some benefit in the MERIT trial, but it does not have an FDA approval, so that would be off-label.
In terms of coverage for management of various aspects of PAH and PAH, including subpopulations, that's not really the role of the health plan. Our job is to make sure that we are covering the standard of care treatments, that those agents, especially when we're talking about expensive and complex and powerful drugs that are used in these conditions, that they're being used in the targeted way to address the groups that the drugs were developed for. We look at the materials and methods sections of all of the pivotal trials to say who are the individuals that the researchers identified as the ones who are the eligible candidates and also the ones who are most likely to respond and do well with these drugs. It is not really the role of the health plan to get into the weeds on how we treat one patient versus another. That's a clinician's responsibility. So at the end of the day, when we're talking about subpopulations or different aspects of PAH and PH, as well as really all other conditions, those are critical decisions for the clinician. And the role of the health plan is just to make sure that those requests, that those treatments are being used within the context of the guidelines and certainly within the context of the FDA label and the pivotal trial results, which should tell all of us who the ideal candidates are. In terms of the data we look at to make medical policy and coverage decisions, we're always looking at the evidence-based literature. What is the information from the pivotal trial results? Who were the patients that the researchers identified as being, first of all, eligible for the treatment, and secondly, the ones who are most likely to respond and do well? We certainly, all of us, want to make sure that these treatments are being targeted as accurately as possible so that we're going to get the maximum and optimal clinical outcomes. We are constantly going back to the literature. We're going back to the FDA as labels may change and expand as new indications or modifications of those indications are added. We're always looking at guidelines from national societies, although I would say that guidelines tend to lag both the evidence-based literature and the FDA labels because of the fact that there is typically a period of time that professional societies need to incorporate new evidence into their guidelines. But the ultimate goal is to make sure that our policies reflect the current standard of care and the current status of the literature.